Hello, everybody. My name's Ed Pavlik, and I want to bring to you another Gyn Onc Garage. Um, my colleague today, in a warmer, cloudy climate than I have, where it's in the 60s, is
Frank Lawton from London, UK, and we're looking for temperatures 33 degrees centigrade over the weekend. So that's going to be hot, hotter than Athens.
absolutely. Well, we're comfortable. All I can tell you is now that's going to change, but we're comfortable right now. Well, let me ask you something here. I thought that was very exciting on Monday when Arsenal was crowned the winner of the Premier League. Uh, is it very exciting there in London, or is that
Well,
not?
it is if you're an Arsenal fan, I suspect. They have been waiting 20 odd years for this. And it's our son is an Arsenal supporter. And it's very interesting that in mid-season they were quite a long way ahead of the Manchester City and whoever else. And they began to lose, and very, very quickly the Arsenal supporters turned very much against their manager. And he said, keep it on. We'll get there. So in a way, I think the fact that his resilience was fantastic. He will do brilliantly now. I think he can do whatever he wants and have enough money to buy whatever he wants for the team. But there's a lot of enjoyment, I think, and even I think people who are not Arsenal fans were quite happy that they'd finally achieved this goal of the Premiership.
Well, they did it with the back line and team defense. That seemed to be outstanding.
Yeah, yeah, they haven't let many goals in.
Well, that's good. Well, did you happen to see the Kentucky Derby by any chance?
No, no. What happened?
Well, if you go to YouTube and find it, you see that the dead last horse, I mean, very much behind the second last horse, came up and won it all the way. And it was really amazing. I never expected that to happen. Okay,
What?
enough for the chat,
Yeah, we better do some work here, I think. Okay.
right? Well, today we're going to consider the question, how does long-term survival in high-grade serous ovarian cancer compare with the survival in the general population? Answer to this question is approached in a paper titled Long-Term Survival in High-Grade Serous Ovarian Cancer Compared with the General U.S. Population. This is a 30-year landmark analysis. This paper was recently published in the JCO Oncology Advances journal. And what we're really going to see is that it compares the high-grade serous ovarian cancer death rate to the death rate in the general population treated at the Mayo Clinic as a function of how long women remained free of events related to recurrence. The goal was to determine how long it took to achieve equivalence. Frank, give us your insights.
Okay. This is a, I don't know whether this is an interesting paper or this is the fact that the 33 authors were sitting around a table somewhere and wondered what can we do because the data, or at least the concept is well known. Long-term survival in ovarian cancer, you do better than if you have a short-term survival. It's true of probably all cancers and probably most diseases. And for years, oncologists have been using 5 years or 7 year survival as a surrogate for cure. And so there's nothing new in the sense that these authors are just looking at long-term survival as an indication that they cured. So I think the data clearly it's a very the clinical data is excellent. There's review of the pathology stage, etc., as we'd expect from an institution like that. So I don't query the data collection at all. Um, but the results they've shown is that at diagnosis, the increased mortality or the mortality for patients with ovarian cancer is 7.4% more than those in the general population without cancer. And this drops to around 5%, i.e., the same as the general population within 10 years. Unfortunately, the numbers are tiny, and I'm not sure that what they've actually claimed is that they can use it in the data. They start with something like 2,000 patients, and the event-free ones, there's only 113, which is only 5% of the total population that they started with. And nearly a quarter of those are FIGO 1 and 2. So you'd expect patients with FIGO 1 stroke 2 disease to do quite well. So I think putting this lot into the same mix does actually weaken the data. I think another problem is going to be if these data are reproduced and patients get to 7 years or 10 years or whatever it is, how are the clinicians going to use these data in order to look after the patients? Are they going to say, okay, ma'am, you're now 7 years out. The chances of you dying of your ovarian cancer are exactly the same as you dying of any other cause of a woman in the United States of the same age. So she's going to say, well, are you going to discharge me now, doctor? And the doctor says, oh, no, 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 we'll keep looking after you because there may be, because we don't know whether or not there's going to be long-term survivors who do relapse. So in other words, the patient says, well, you're telling me that I'm going to be all right, but you want to keep looking after me. And I think that's going to be the dichotomy that a paper like this is going to produce. When do you stop? When do you say, we've done everything we can, you're as cured as we can make you, and I think it's time that we just say you're going to be fine. So I think the data are good. I just think the conclusions and what they think that the data leads to is very, very wishy-washy. It doesn't tell me anything I didn't already know, and I suspect that's true of a lot of oncologists.
Well, I think you're right, Frank. I want to look at their data here for a second just to make sure that everybody sort of understands why we have a particular view. But when they started this particular study, you can see that somewhat the probability of an event, which means anything from an imaging of a new recurrence to CA-125 going up, separated the ovarian cancer deaths from the in black the regular population. After 2 years, you've taken out the people who've had an event. In other words, they've had some evidence of recurrence, and what we see is that there's a lessening of the curves between the ovarian cancer deaths and the general population in black. If we go another 5 years and consider what's happened now, if you take out of the population those individuals that have had an event related to a recurrence, let's say, once again, everything is collapsing even more in panel C. And if we go out to the 10-year mark, which is really the element that they've done, everything is collapsed so that the red line, which is the ovarian cancer death line, is just the same as the black line for the general population. And there's where Frank's point is really quite spot on, and that's that out here in panel D, have we selected for all the cancers that really had a good expectation, and out of their list, this could be just the early stage 1 and stage 2 diseases, which the ultimate numbers of who are left down here at the bottom right are just about what they started with. So with regard to early stage disease. So, my view is, have you selected for type 1s, early stage, poorly differentiated versus as going out and it's not surviving well versus highly differentiated? People started out with no evidence of disease after surgery. And do you have an advantage for interval cytoreduction? And I think the last thing I'd say is that about this paper, the Mayo Clinic population really doesn't reflect the general population in the U.S. It's a wonderful institution with very good clinical care and very good reputation, very good doctors, but really there's a selection for the people who can afford to go to a Mayo Clinic site, and those people generally are affluent and don't suffer from any of the disease disparities that characterize the U.S. population. So that's me, Frank. That's all I have to say on that.
I think, as I was saying, the numbers are quite small, but it would have been interesting if they determined what are the long-term survivors. A lot of them were stage 1 and 2, but are there other factors? Do PARP inhibitors make a difference now? Is maintenance chemotherapy, which is very much used, one of the factors that leads to it is ultra radical surgery, and they've not looked at that, which I think weakens the paper. I know the numbers are small, and perhaps this might just engender some studies from other institutions, or even to put in collaborative data to see if they can get bigger numbers to answer that question. Um, that's my point anyway.
Okay, well, there's no need to belabor the point anymore. We've done another one, and we'll do another one next week. Next month,
Okay.
excuse me. Okay, I'll see you, Frank.
Yep. See you soon.